For a session on preventing the first malignant cell, please welcome Dr. Robert Nussbaum, Chief Medical Officer of Invitae, Dr. Diane Simeone, Director of the Pancreatic Cancer Center at NYU Perlmutter Cancer Center, and Steve Kafka, the Executive Chairman of Thrive Earlier Detection. Here to lead the conversation, welcome back Jeanne Meserve.
Thank you all, and thank you for being here. Wouldn't it be great to stop cancer before it begins? And our understanding of genetics, our use of genetics are taking us closer there. Amy just talked about it a little bit. We're going to talk about it some more. Diane, I want to start with you.
Okay.
You deal with pancreatic cancer. Relatively rare, but
Not
nearly,
that rare.
nearly always a bad outcome.
Yeah. So raise your hand if you know someone that you care about that's died of pancreatic cancer. Not so rare.
Wow.
Yeah.
But bad outcomes usually
Yeah.
because of late diagnosis.
Correct.
Does genetic testing help you get an earlier diagnosis? And what difference does that make to treatment?
Yeah. So I think there was an underappreciation of the contribution of genetics to pancreatic cancer. And others have embarked on a set of studies to do germline testing or testing to see if people carried susceptibility genes that had pancreatic cancer. It's at least 15% of patients with pancreatic cancer that have a susceptibility gene, even if they don't have a family history that would point to that. And so we have worked with ASCO, American Society of Clinical Oncology, to have that become now the standard that all patients with pancreatic cancer should get germline testing. It affects their own care because sometimes we give patients therapies based on what that test shows, but it also helps us identify family members who are also at risk with the big move towards early detection.
Can it also potentially get us to prevention?
I think so. I think if we assemble a large enough cohort of individuals who are at high risk, then we have the ability to do prevention studies that are statistically powered.
Steve, you do liquid biopsies. First, tell us exactly what that is.
It's a fancy word for basically a blood test. And
And this is new science.
well, it is actually really new science. And I think that the exciting part about where we are right now is we are right on this cusp of a real paradigm shift in cancer survivorship and the ability to really detect cancer earlier. And I think the key phrase there is earlier as opposed to just early, because we know that not just at stage 1 and stage 2, but even in the localized stage 3, the opportunities to intervene are significantly improved. And so what we're doing with a blood-based test, we'll call it that to keep it simple, is to actually, I think a little bit in contrast to some of the discussion around the germline testing, is to ultimately aim towards the testing of healthy individuals as part of your routine care. So to do for cancer what we've basically done for cardiovascular disease over the past 50 or 60 years, as part of your annual or biannual physical, with a relatively small amount of blood, be able to look for circulating signs of actual cancer in your system and provide that information back to the physician in such a way that we can then decide what the appropriate course of action is.
So, Bob, your company is offering genetic testing. Yep. So is 23andMe.
Right.
What's the difference between what they're offering and what you're doing?
Well, the difference is really primarily, number one, is comprehensiveness. If you think of all the genes that might contribute to a cancer predisposition being like multiple chapters of a book, what we do is proofread every word of every chapter through the whole book. We're not just looking at 3 words in 2 chapters and asking, are those 3 words misspelled or not? The other big difference, of course, is that what Invitae offers is a medically valid and validated test that is the same that physicians use. I mean, it is a test that physicians use. If you get a positive result or a negative result, it's a reliable clinical test. You don't have to go someplace like Invitae to get the test repeated to either confirm a positive or find out whether the negative was really not as negative as you thought.
And do you provide genetic counseling along with the results?
We do. We provide genetic counseling. The company has counselors, plus we also refer people to local counselors. There's not enough genetic counselors to
Yeah,
go
I was going to
around.
say, are there 2 or 3 jobs for every counselor?
Yeah, there are enough to go around. And so part of what Invitae is doing, and we recently just acquired a company that focuses on this, is figuring out how to use artificial intelligence and chatbots to be able to provide the routine information that is needed so that we can reserve for the counselors the serious counseling needs to be done when people are faced with serious decisions.
Do people want to know that they have these things? For instance, a blood test. Do they really want to know that they have markers for certain kinds of cancer?
I mean, I certainly think they should, because information is power, and you can then decide what to do with it. I think it's a similar question to what, we face honestly with other diseases. Do you want to know that you have high cholesterol, that you have high blood pressure? I think that there's, particularly what's key here is that you should want to know, and we want to be able to share this, when there is well-grounded science behind what we're reporting back to that to that patient and that physician, and that it's done with a very high degree of fidelity so that the information is actually actionable.
So just because you have a genetic predisposition to a cancer doesn't mean you're necessarily going to get it. There are other factors at play, environment, age, etc. So could it lead to overdiagnosis? Could it lead to overtreatment, doing this kind of genetic screening on a routine basis? Do you want to handle that, Diane?
So I think it's a very important point, and that comes up all the time in the pancreatic cancer space. First of all, this question's come up, should I know? And I think the concern is, what can I do about it? And it's important to realize there is something we can do about it. There actually are 2 studies now, they're not huge, but they're each a couple hundred patients, that show for patients who have a genetic susceptibility to pancreatic cancer, if they're in a screening program, and by that I mean annual imaging of the pancreas, that if they were to develop a pancreatic cancer, we can detect it when it's much smaller than you would otherwise detect it, and our ability to remove it surgically can approach 90% as opposed to the typical 15% that we see. But it's also important to know that we don't make these decisions lightly about who we do or do not take to surgery. We do all of this in the context of a multidisciplinary team where we really give a lot of thought to what the best approach is for every patient.
Chief, can I make,
yeah,
sorry, just to interrupt,
please,
but I want to make sure we have an important distinction between detection for enhanced risk of cancer versus actual detection of cancer. And I think there's a distinction here that's important. When we talk about colonoscopy or mammography, that's actual detection of cancer. When we do a BRCA screen or other sorts of genetic predispositions, that's enhanced risk. And so part of this question about should we want to know or not is I really think a function of how good is that test. One of the challenges with our standards of care today are that the false positive rates on those tests can be pretty high, and so that that induces additional cost, psychological cost as well for the person who's receiving that result. And so, thinking about a test for cancer, the presence of cancer, which is what we're doing, looking for circulating markers in the blood itself. If we can do that with a very high level of the scientific term is specificity, or really minimizing those false positive results, then the information that you're getting back to say we detected actual cancer, we believe then makes that a much more actionable conversation for the physician. Now, whether you do something about it is sort of the next step, but the actual presence of cancer here, I think, is an important distinction.
So what percentage of false positives do you see? So
the technology that we're using is coming out of Johns Hopkins University. It's a test that's called CancerSeek, and it's been studied both in a retrospective large study population and now also in a patient population of 10,000 individuals. We're seeing a specificity that exceeds 99.2% or a less than 1% false positive rate.
How about you, Bob?
Right. So that's a very important point to make because part of what needs to go into the calculation, it's not just what the false positive rate is, it's when it's applied to a population. The prevalence of the condition you're testing for plays a huge role. So if it's very rare, even a 99% specificity may result in a lot of false positive predictions in the population. Mm-hmm. For germline testing, we still have a lot to learn.
Yeah, we don't even know which genes are associated with which cancers in every case.
We know some. We know some, we don't know them all. But the other bigger problem, and one that I think needs to be addressed, is that when we find a difference in a gene, that doesn't necessarily mean that difference is causing that gene not to work. And so a typical germline test does not have 2 outcomes, positive or negative. It has 3, positive, negative, and it's a variant of uncertain significance that we don't know what it means. And one serious issue is that we don't have enough data from people that are not from Northern European backgrounds to be able to interpret these variants. So the variant interpretation is more difficult. We desperately need more data from the worldwide population to be able to do the best job we can.
And efforts are underway to try and accumulate that data. And I have to imagine that artificial intelligence is a huge tool.
It is,
In all of this.
because the data collections now, I mean, for example, my company has just recently passed the 1 millionth test mark. And there's a huge amounts of data out there. The All For Us, which is coming from NIH, is going to provide more information. The more data you have, the better job we can do.
Let me come at this from a different angle. We've talked about the danger of false positives, but what if you have a genetic screen and it gives you a clean bill of health, and then you develop cancer? Have you been given a false sense of security by genetic testing?
Yeah, that certainly can happen. It's because the genetic testing does not cover everything that happens. I mean, there's a lot of cancer that develops because something happens in a cell that's not what you inherited. It's not in every cell of your body, it's in that cell, what we call a somatic change. Right. And we think a lot of cancer develops that way.
I think,
But it isn't, I do want to point out, if you actually look at families where there's a lot of pancreatic cancer, and we do susceptibility testing, germline testing, which tests a panel of 40-something genes, if you get the Invitae assay, of which 15 are associated with pancreatic cancer. 80% of families that they have multiple family members with pancreas cancer, the test will be negative. And I think that highlights that we still have an incomplete understanding of the genetic risk associated with cancers.
This question of false negatives, which is another way of asking what you're asking about, I think is really important, but it's also relevant to think about what the starting point is, because we do have many, many cancers today that really do not have screening methods at all. And so the sensitivity or the rate at which you find those cancers is essentially zero because we don't look for them, or it's very low. And there is a bit of a distinction here too. I think we've talked about therapeutics in this meeting as well. You know, if we had a therapeutic that worked in 30 or 40 or 50% of patients, in many cases we're celebrating that's a home run. And so the fact that if we find, in 30 or 40 or 50% of patients we're able to detect a cancer earlier, we're still missing some, it's not working for everyone, that we have a different level of expectation about what that should be, I think is something that we should think about. No test is ever going to be perfect. So it's a question of, sort of what's the balance.
We're going to take your questions in a moment, so type them into Slido if you would. Let me ask you a question about if ultimately this kind of testing, because of early diagnosis or perhaps prevention, is going to help address questions of accessibility of medical care and the cost of medical care. Who wants to grab that one first?
Well, I can talk about the cost. I mean, the cost of doing a full-scale comprehensive genetic test for, let's say, all the hereditary cancer genes is about 1/20th of what it was just a few years ago.
How much is it?
So $250. And it's only going to go down. If you think about the whole Human Genome Project, that cost $3 billion to do the first human genome. Now you can get a whole genome for under $1,000. So the change in the cost structure for this is enormous. Now, it does not take into account the point you made, a good one, and that is what happens with downstream costs. And I find, in fact, that most medical economic discussions about this really miss what I think are some key issues here, and that is, it's not just what the downstream cost is of surveillance, is what did you prevent, and how much useful life do you end up being able to find things, intervene, and have people get back to work running advertising firms, for example.
Right.
And it's much more expensive to take care of an advanced cancer than to make that investment for early detection. We really have to shift the whole paradigm to the left.
Privacy question for you. Insurance companies get hold of this data potentially. It impacts my health care.
It's against the law.
Yeah, so
against the
there is a law that called GINA, G-I-N-A, Genetic Information Non-Discrimination Act, which says that genetic information cannot be used for either health insurance or for employment. Does not, on a national level, does not cover life insurance, although in some states it does. So there's a patchwork quilt of protection here. I should say that in general, life insurance companies are much more interested in whether you have sugar in your urine and whether you have high blood pressure than they are as to whether you've had a genetic test.
I will just say they denied me because of a genetic test for cancer.
I've seen that happen
Yeah.
too, and so I usually instruct my patients to make sure that they have their life insurance
Before they get
before
tested.
they get the test.
That's a routine
Let's
part of
take a
cancer.
couple of questions. While screening for cancer, could we screen drug metabolism genes so we could manage all medications better, especially in minimizing chemotherapy ADRs?
The answer to that is clearly yes. We already know some of the genetic changes that predispose, for example, to the cardiomyopathy that occurs, the heart muscle damage that occurs with certain chemotherapeutic agents like anthracycline. We know that that's mutations in the Titin gene. So the ability to do a large-scale pharmacogenetic screen is clearly something that we need and can do. The number one obstacle is that that information should not be obtained when you think you might need it. It should be obtained in advance, have it in the electronic medical record so it's already available. If you sort of depend on people ordering individual pharmacogenetic tests as needed, it'll never get done or utilized.
Well, I just add, I agree with what Bob just said. I think that, though, there's some wisdom in taking maybe baby steps before we run too fast, and how much information do we really want to be gathering at once? Because the barriers here to adoption are going to be significant, whether it's payers paying for it, whether it's physicians, agreeing to use it, whether it's the access question of how do we make sure that it's broadly distributed. And so I think we can and should go here as well, but let's do it in a way that's really going to maximize the adoption, I think, and therefore the benefit.
Another audience question, if you have to choose a focus, where should this work focus? Early detection of genetic markers versus actual cancer?
Well, I don't
Yes.
think they're mutually exclusive,
Yeah, I
right? I
agree.
work on pancreatic cancer, and there are two big areas of focus we're really working on in the field, which are changing how we do clinical trials and really going after early detection for the disease. So, until we solve early detection and prevention, we have lots of patients that are in desperate need of more effective therapies. So I think we still have to work on both those paths until we get where we want to be.
Steve, you obviously see this as a good investment. Is there enough money overall being put into this field of research?
No, there's not. I think that we've historically put an awful lot of our capital and time and energy into really the later stage disease. And it's not to say that we should dial back on that at all. I think those are really important investments to continue to make. But the step change impact that we can have in survivorship when cancer is detected early, the economic impact, certainly the human and patient impact here, is, I think, going to be orders of magnitude different. I mean, I spent 5 years working at Foundation Medicine, really helping to develop, some of the initial comprehensive genomic profiling that's helping to match patients to the right therapy, especially in the late stage. And what makes me so excited about this earlier detection opportunity is I do think this is going to be 10 times or more the kind of impact. So more capital should be going here. It'll pay off.
Another audience question, what are some near-term steps to move the needle on developing a better understanding of minority populations? Something you brought up, Bob.
So the National Institute of Health is focusing on this very heavily. So the All for Us program, which is this 1 million individual cohort, they are emphasizing and specifying that a certain fraction of the population has to come from people that are not of Northern European origin. There's also a big move, there's something called H3 Africa, which comes out of NIH, which not only is gathering genetic information about people living in Africa, it is empowering African scientists to become genetics researchers in Africa. So it is a really, teach somebody to fish and they can live off of fishing. So that's another big aspect. And the other is, I have to say, that non-European origin individuals should recognize that their health care would be improved by participating in research.
Should people be routinely genetically screened, and when should it happen?
Well, we do offer what we call a genetic health screen to adults. It has to be over age 18. We don't offer it to children. And it is essentially all the major hereditary forms of cancer and cardiovascular disease for which there are interventions. So there has to be actionability. And we're running somewhere about approximately 6% positive rate for either one of the cardiovascular gene mutations or one of the hereditary cancer mutations. And that's not these variants of uncertain significance. These are all bona fide known disease-causing changes. So I think population-based screening is coming and will become part of, but only part of, an approach to general health.
Bob, Diane, Steve, thank you all. Appreciate your insights on
Thank you.
this today.
Thank you.
Thanks.